Hi, everyone. Today we'll be presenting interdisciplinary care of eating disorders, what the treatment team needs to know. My name is Emily Whitaker, and I'm presenting with JPierce. We're both nursing students in the PMHNP program at Southeastern Louisiana University. Before we begin, here are our learning objectives for today. By the end of using Patricia Brenner's Novice-to-Expert framework to structure this presentation. Please take a moment now to scan the QR code on the screen and complete the pretest. This will help establish your baseline knowledge before we begin the content. This slide shows the DSM-5 spectrum of feeding and eating disorders. Eating disorders are associated with significant mortality. Each year, despite how serious these illnesses are, only about 20% of individuals with an eating disorder receive treatment. This highlights the importance of early recognition and referral by all members of the healthcare team. This slide emphasizes an important and hopeful point. With appropriate treatment, there are many common myths surrounding eating disorders. These include beliefs that people just need to eat more or less, that only underweight people have eating disorders, that eating disorders are lifestyle choices, or that people are seeking attention. These misconceptions contribute to delayed diagnosis and stigma. The realities of eating disorders include increased suicide and medical risk. Effective eating disorder treatment requires a coordinated interdisciplinary team. Primary care providers manage medical monitoring and stabilization. Psychiatrists and PMHNPs focus on diagnosis, risk assessment, comorbidities, medication management, and level of care decisions. Dietitians guide nutritional rehabilitation and monitor deficiencies. Nurses provide ongoing monitoring, education, and escalation of concerns. Therapists deliver evidence-based psychotherapy, and social workers and case managers support care coordination and family needs. Family members play a critical role in meal support and treatment adherence. Anorexia nervosa is characterized by food restriction. Family-based treatment is the first-line intervention for adolescents with anorexia nervosa. Bulimia nervosa involves recurrent binge eating with loss of control and compensatory behaviors such as vomiting, laxative use, fasting, or excessive exercise. Medical risks include electrolyte abnormalities, especially hypokalemia, dehydration, syncope, and GI complications. Urgent red flags include chest pain, palpitations, severe weakness, frequent purging, and active suicidality. First-line treatment for bulimia nervosa is cognitive behavioral therapy, or CBT-E. For adolescents, family-based treatment for bulimia is recommended. Fluoxetine may be used as an adjunct for persistent symptoms or comorbid anxiety or depression. Weekly tracking should include binge and purge frequency, skipped meals, compensatory behaviors, medical symptoms, and safety indicators. Assessment should include electrolyte monitoring, orthostatic vitals when indicated, EKGs when clinically necessary, and screening for suicidality. Eating disorder is characterized by recurrent binge episodes with loss of. First-line treatment includes cognitive behavioral therapy focused on binge eating. Avoidant restrictive food intake disorder involves restriction or avoidance and is multidisciplinary and typically outpatient. CBT-AR. Pica involves persistent ingestion of non-nutritive substances such as dirt, paper, chalk, or hair. Complications may include GI obstruction, toxicity, infection, and dental injury. It can occur across the lifespan and is more common in pregnancy and neurodevelopmental disorders. Treatment focuses first on medical safety. Behavioral interventions are first line. Outcomes to track include frequency of pica behaviors, medical complications, and safety events. Assessment should be directed and non-judgmental with careful evaluation of substance type, triggers, and contributing factors. Rumination disorder involves repeated effortless regurgitation of food after meals that is not associated with nausea and is not due to another medical condition. It can lead to weight loss, malnutrition, dental erosion, and psychosocial impairment. First-line treatment includes habit reversal techniques using diaphragmatic breathing. Outcomes include reduction in regurgitation episodes, improved nutrition and hydration, and improved functional participation. Assessment should rule out GI conditions and screen for anxiety, autism spectrum disorder, and intellectual disability. This slide summarizes key clinical differences between anorexia nervosa, bulimia nervosa, binge eating disorder, and ARFID. Pay particular attention to whether restriction is driven by weight and shape concerns, whether compensatory behaviors are present, and the primary medical risks associated with each condition. Long-term management focuses on monitoring psychiatric safety, medical. At this point, we will pause and walk through our first case vignette. In this case, the most likely diagnosis is anorexia nervosa. Let's move to our second case involving a college student presenting with. The correct diagnosis is bulimia nervosa. Medical evaluation. Our final case focuses on a younger patient with food avoidance following a chip. This presentation is most consistent with ARFID. Please take a moment to scan the QR code and complete the post-test. During her adolescent and young adult years, Paulina Gage navigated